Thank you. I appreciate everybody jumping on, and thank you, Lauren, for inviting me to do this. This was actually, I'm so glad I'm doing this because this was an opportunity, frankly, for me to take a closer look at what's going on in Oregon. And as I was just telling Lauren, the process there when it comes to the Prescription Drug Affordability Board, it was frankly even confusing to me. So I'm going to do my best to walk through what I have learned in looking into it. And then also, as we go through, talk, I hope, a little bit about what we are seeing in some of the other states. But there are other advocates. Sari Vyeth's on the phone, who has had some experience with this in the Colorado Prescription Drug Affordability Board. And there are a couple of other advocates that may join partway into this that also I think would be in a good place to chime in to talk about their own experiences. So anyway, with that, I'm going to go ahead and get started. So just a little bit about PIPSI, the Partnership to Improve Patient Care. We are a coalition that was started by Tony Coelho, who is a former congressman from California that authored the Americans with Disabilities Act. And as many of you know, Tony continues to be a very active disability advocate. He's also a person with epilepsy. And so he comes at these issues really very personally. So when PIPSI first came together, we really were focused very much on the creation of PCORI, the Patient-Centered Outcomes Research Institute, which if you look back and you think to like 2008, right, Congress was hotly debating comparative effectiveness research and whether or not to create an entity that would do comparative effectiveness research. And it was an interesting debate. And I think it's interesting to me because I think it's all kind of coming back and playing out again now. Back then, when we were creating PCORI, the debate from the far left extreme was we should create this entity to do cost effectiveness analysis, and the cost effectiveness analysis should then inform Medicare decisions and what we do or do not cover. The far right sort of perspective was that's going to lead to cookbook medicine. We don't want doctors telling, we don't want payers telling doctors what to do and what to prescribe. We shouldn't be paying for this, that kind of perspective, right? So the PCORI was actually created as a compromise where PCORI does comparative clinical effectiveness research. They don't do cost effectiveness. And there is an explicit piece of the statute that says that the comparison between two treatments needs to look at subpopulations to understand not just to come up to a conclusion that A works better than B, right? But to say that A works for these people and here's why, B works for these people and here's why. And oh, by the way, that evidence can't be used to make coverage decisions. Oh, and by the way, we're going to bar the use of discriminatory measures as part of that. So PIPSI was really at the center of a lot of those compromises because patients really wanted this comparative effectiveness research, but they didn't want it to be used against them. And so I prefaced this whole conversation with that because I think that's a little bit too of what's playing out in some of these PDABs. So PIPSI was also very engaged, as I'm sure many of you are, in the COVID-19 pandemic around crisis standards of care and really pushing back against measures of discriminatory measures being used to determine who kind of gets to the front of the line for care in a shortage and who goes to the back of the line. And so we've also then now, because of increased use of these discriminatory measures called quality adjusted life years, which I'm going to talk a lot about, we've been sort of at the forefront of saying we need to extend the quality band that was in PCORI's statute as part of the Affordable Care Act into other programs. So this quality adjusted life year measure is really troubling and is something that we have been seeing crop up in a lot of state Medicaid programs. But it all started in Oregon. So we're going to talk a little bit about that too. So the QALY is a means of measuring healthcare. It looks at healthcare quality and quality of life and improvement. So first, when you look at the base measure of a disease, you have one perfect health, 0 is death, and somewhere in between is where most of us fall, depending on what kinds of health conditions we live with. So this is a really good, I think, way of looking at that. So you have, I always, 0.5 is like if you person with MS, the quality score is at a 0.5, which means that when you're measuring the value of someone's life in that year, it's half of someone who is young and in perfect health. You also have these things called negative utilities, which if you look all the way to the left, you'll see ALS, which is at a negative 0.5, right? And those are conditions that based on a quality score would be considered worse than death, essentially. So you can imagine that if you're using these kinds of measures to measure the value of healthcare for these patients, there's the potential for those treatments to be devalued because the value of those people's lives are considered less than whole. And so when you're measuring the quality, it really goes beyond, because you'll hear in a lot of places, and we're actually dealing with this in the context of some potential federal regulations, at least as proposed. The quality goes beyond how we look at life extension, right? The quality is very obviously discriminatory in the sense that it devalues a person who lives with a life with a chronic condition or disability. And so when you're looking at life extension, right, you're extending a life that's worth 0.5, but it actually goes beyond just being discriminatory in the context of life extension. One of the big problems too with the quality is this process of translating clinical outcomes into utility scores, right? When you look at, there's a utility score called the EQ5D, which is based on these sort of broad-based surveys that look very broadly at, one of the very first question, right? If you think about this in the context of ableism, right? The very first question that the EQ5D asks a person to measure their quality of life is whether or not they are able to walk about. So from the get-go, you're looking at a discriminatory measure of someone's quality of life, and the quality is all about how a treatment improves their quality of life, right? So if your measure is whether you can walk about, and you're never going to get to a place where you can walk about, then that treatment's not going to look like it's particularly effective, even if it is particularly effective in other ways. Also, people with disabilities may attach different values to their own health states than the general public. So a lot of times there are these broad-based public surveys too that go into these scores where, and there's a lot of studies out there that show that there's a tremendous amount of disability bias among the public, particularly in different sections. But those are the scores that then sort of feed into, so think about, I know we dealt with this on one of the value assessment processes for spinal muscular atrophy, where, the question was, well, how much value does it have that this treatment would then allow a child to be able to sit up in bed by themselves? Right. Well, for families and for people who are, trying to maintain as much independence as possible, that's a really big deal. Right. But in terms of how it scored in terms of a quality of life improvement, and some value assessments, they may not score as being significant. Right. And so that's why it's really important for patients and people with disabilities to be very involved in these kinds of studies. And also you have the issue of quality-based value assessment being very unlikely to account for clinical knowledge that's based on patient variation, but it hasn't made it into the research literature yet, right? And so this has a particular impact on vulnerable populations. So if you think about it, and in Oregon, you have a very significant focus on health equity, which is great, except that these kinds of quality-based models, because they rely on randomized clinical trials, those trials tend to not be particularly representative of participants who are not, white, middle-aged. That means that their models are really not capturing data that's applicable to other populations. And then you have also that there's an omission of attention to the evidence that things like pollution, food insecurity may have on the expression of disease and illness. So you think about this in the context of like social determinants of health. Those typically are not incorporated into a value assessment model. And so this slide underscores the extent to which, if we were to rely on a quality-based value measure, what that would mean in terms of coverage, right? And in these studies, looking particularly at psoriasis, multiple myeloma, small cell lung cancer, and multiple sclerosis, rheumatoid arthritis, you would see people having to switch treatments because of those assessments, particularly those assessments as conducted by an entity called the Institute for Clinical and Economic Review, which is an entity that does a lot of cost effectiveness analyses for new drugs. We also, if you look at these models using value assessments, we have, there's a lot of studies that have looked at other countries that tend to use these models. And typically in these other countries, there's a tremendous amount of disability bias. And you find that these countries will delay or deny treatment for conditions. So they're not getting access to the kind of the latest and greatest. So, these are just examples. Breast, colon, lung, prostate cancers, 5-year survival rates are higher in the US than in Canada, France, Germany, Italy, Japan, the UK. You tend to see fewer options. This particular study was just looking at cancer medications. And you also, in other countries, would have access later than you would in the United States. So this issue around the QALY is interesting. So there was a recent proposed rule, we call it the Section 504 rule, that really responded to a lot of these historic concerns, right? So you had Section 504 of the Rehab Act, which is the law that basically says we can't discriminate against people with disabilities in any program, including Medicare. And then you had 1990, the Americans with Disabilities Act passed. And then in 1992, you see in Oregon proposed to use a QALY as part of its development of a prioritized list of services. When Oregon did that, HHS denied the waiver and said, no, you can't do that. That would violate the Americans with Disabilities Act because basing your prioritized list on a QALY would be discriminatory. Now, and we'll talk about this a little bit more, Oregon, we have found out, did use QALYs, and there's now an effort against their use of QALYs in the prioritized list of services again. But this sort of all started in Oregon in terms of identifying the QALY as a discriminatory measure. In 2010, we have, Medicare banned the use of QALYs and similar measures, as I mentioned before, as part of the PCORI statute and the Affordable Care Act. In 2022, there was language included in the Inflation Reduction Act, which is related to the new drug negotiation program, that basically said you can't use comparative clinical effectiveness research that devalues people with disabilities and older adults in negotiation using language that's very similar to what's in the Affordable Care Act. And then you had the Office of Civil Rights propose rules related to Section 1557, which is the non-discrimination provisions of the Affordable Care Act. And then also last year, we saw introduction of legislation in the House of Representatives that would have extended that QALY ban that's in the Affordable Care Act, where they ban the terms is QALYs and similar measures. That would be extended to other programs, including Medicaid, and that legislation is still pending. It has not passed, but it is intended to get at these issues that you're dealing with in states like Oregon and other states, where we're trying to make sure that the value of healthcare, whether it's prescription drugs or otherwise, are not based on these discriminatory measures. And we'll share these slides. I'm not going to belabor this one. I just added it actually right before our call because I think there were some really interesting comments on the Section 504 rule that were very, I found them to be really insightful. A lot of the organizations that commented back particularly made statements about a measure called the Equal Value Life Year Gained, which is a sort of a side-by-side measure that the Institute for Clinical and Economic Review, ICER, uses alongside a quality adjusted life year in its reports. And they've been advocating, if you're not going to use the quality, just use this EVLYG thing. And at the end of the day, a lot of people in the disability community have been very opposed to that, because that measure still uses these biased health utilities that are based on inadequate surveys or biased surveys. So as I mentioned, back in 1992, Oregon tried to use QALYs to develop its prioritized list of services. 30 years later, it comes to light based on advocacy from folks on this call that really pushed to get more information from the HRC as to how they're making decisions. And it came to light that they were still in some ways using QALYs to develop their prioritized list of services. And so there's been a tremendous amount of really positive advocacy from Oregon advocates to the health, to the HRC, which is the entity that makes these decisions, calling for them to do something different, and also calling for them to better engage with patients and people with disabilities in the context of their decisions. Based on what I'm seeing in terms of the Prescription Drug Affordability Board, which is what we're here to discuss, it sounds like some of those lessons have not necessarily translated. But hopefully when I'm done, we can get some feedback from some of the Oregon advocates that were involved in the HRC process as well. Also, there is legislation at the Oregon state level that looks to bar QALYs and similar measures, similar to what's in the Affordable Care Act, that I understand to be considered in the next legislative session. As background, Oklahoma has passed a statewide ban on QALYs and similar measures. Massachusetts is considering such a ban. There is pending legislation in Massachusetts as well. So there is some precedent for it. Now, when we get into the PDABs, when the legislation was being considered, we were following it very closely, and I know a lot of the advocates that were in Oregon were actively working to make sure that it barred QALYs and that it called for engagement. So there are some provisions in the bill that look to limit the use of quality adjusted life years. I do think, just based on what I am seeing in terms of presentations to the board and what they're doing, it does sound like there could potentially be some quality adjusted life year measures that are seeping into the process. If you look at the actual legislative language, it talks about not being able to use QALYs to identify subpopulations for which a prescription drug would be less cost effective. I'm not sure how that's being interpreted by the board at this point. And again, welcome feedback on this when we get to the end of this presentation, because there may be some of the advocates in Oregon that understand how this is being interpreted better than I do. And so the way that the Oregon PDAB kind of came to be was in 2021, there was legislation that created the PDAB. The PDAB was called upon to make recommendations back to the legislature that would then be incorporated into another bill. That happened. And one of the explicit things in that bill was allowing for them to look at options such as upper payment limits for drugs that are deemed to be unaffordable. And so there was a report back to the legislature from the original Prescription Drug Affordability Board that led to this next piece of legislation, SB 192, where basically the legislature said, okay, we're going to call for a yearly report due December 15th every year. And that includes recommendations for legislative changes. Also, again, reference to the potential for use of an upper payment limit, because the PDAB had actually recommended back to the legislature to create an upper payment limit, which it does not look like they did in that piece of legislation. But as I understand it, the PDAB has asked the legislature for more time because they haven't been able to get through their process, which is understandable because it's a really time-intensive sort of process to go through. In Oregon, the PDAB structure is that you have 8 board members. None of them are patients. They're designated to be by statute residents of Oregon with expertise in healthcare economics and clinical medicine, but not patients. So in terms of the PDAB process, the Department of Consumer and Business Services, as I understand it from the legislation, provides the PDAB each calendar quarter a list of drugs. The board is supposed to, at the end of the day, identify at least 9 drugs and 1 insulin product that may create affordability challenges. Now, the drugs that were recently selected, from what I can tell, did not include any consideration of out-of-pocket costs for patients. It was really just based on manufacturer and payer information that they got. So they chose 26 drugs, which is, I think, interesting. And I'll be interested to hear what the Colorado advocates have to say, because there's only 5 that are going through an affordability review in Colorado. And I think even there, that seems like a lot. So 26 is a lot. And the board is going to have to narrow that, though, and intends to do so based on these previous meetings by February or March, which is not very much time. So thinking about this in the context of engagement, as I understand it from the website, to speak at a PDAB meeting, you have to request to do so 24 hours before the meeting, which means that for their next meeting, which is on December 13th, people will need to request to speak by 9 a.m. on the 12th. For written comments, they have to be submitted no later than 72 hours before the PDAB meeting, and they will be posted online. So that would be 9 a.m. on December 10th. What's interesting to me is that there's no opportunity to just sort of chime in at these meetings, or like kind of an open comment period where if you hear something at the meeting that you go, I really want to ask about that. Those opportunities don't exist. If you're not registered to talk, and if you haven't submitted your comments 3 days early, you're not going to have an opportunity to participate. So in an interesting conversation I was having with a disability advocate recently, I think there's a distinction between engagement and communication, right? And so I think as everyone is moving forward in these processes, and I know that this is something that we're going to be focusing on as PIPSI as well. It's the difference between just engaging, listening, right? There's a lot of listening sessions that happen in these contexts. And there's a big difference between that kind of like listening session where you're just taking information in, and communication where you have an opportunity for a back and forth. And I think that's what I'm not seeing in this process at this point in Oregon. So some of the concerns that just jumped to my mind, and I'd love for this to be part of the conversation. There's a group called Portal that is a contract entity out of Boston. They actually have a contract with ICER in Boston in their work with their Health Policy Commission. Portal is a very pro-quality, pro-EBLYG entity, does work for payers. They've been engaged in the Colorado PDAB process, and they have done presentations now to the Oregon Prescription Drug Affordability Board. There was a presentation they did at the February 2023 meeting, talking about eligible drugs for an affordability review, where they very explicitly talked about QALYs and EBLYGs and how to use them. They recommended using existing health technology assessments, which would essentially be from ICER, because that tends to be who does these types of assessments. They explicitly referenced ICER's evidence rating in terms of what's good evidence. So anyway, so that to me is concerning, especially in the context of what I think advocates imagined to be a QALY ban that was in the legislation when the PDAB was passed. It's also unclear how orphan drugs are going to be treated going forward in the legislation. It says that orphan drugs are supposed to be excluded, but I think the conversation that has been happening at the Oregon level makes it unclear whether a drug that has a non-orphan indication could also be considered. And then it's obviously concerning that there's no patient disability representation on the board. And it's also unclear to me the extent to which out-of-pocket costs are going to be weighted in terms of what is affordable and what is not. And for example, like if you look at the 26, like there's some in that 26, there are some like whole classes of drugs that are listed, with albuterol being one, which I guess to me, like that's never been something that's come up to me as something that's unaffordable. So it's going to be interesting to me in terms of how they move forward with these decisions, what they're basing that on. So there's also some confusion. If you look at the Prescription Drug Affordability Board website in Oregon, front and center is this meeting on December 7th. That is not a PDAB meeting. It is a meeting that is held each year on prescription drug pricing that is not a PDAB meeting. It is a meeting that is moderated by people in the legislature. So I still think it's a great meeting for Oregon advocates to want to participate in. That entity also, as part of their annual report, has recommended an upper payment limit. So I think it's certainly something that advocates want to participate in, but don't be confused. It's not a PDAB meeting. And so a few just highlights, and then I want to have Siri speak a little bit more, but in terms of comparing to Colorado, which has a prescription drug affordability board that is very much up and running. Their board is a 5-member board, but they also have a 15-member prescription drug affordability advisory council, which does include patients, even though the board does not. Now, they did select 5 drugs for affordability reviews in August. And I think it's been a big concern there around what's happening with orphan drugs, because they don't have the same kind of orphan drug exclusion that Oregon does. And I also understand that they had engagement sessions for patients and then engagement sessions for clinicians and researchers. So there has been some engagement, even if the process isn't necessarily transparent. So anyway, I don't know, Siri, if I could get you to chime in here, because I'd love to learn more about what your experience has been in Colorado.
Thank you, Sarah. Well, Colorado, it's been a long, strange trip. It's starting from the very beginning. I think when they first were going to pass the legislation, we testified that we are very concerned about the use of quality adjusted life year measures, no carve out for rare disease drugs. And it's still advanced. So then they hit the ground running. And their first meeting was it wasn't a meeting of the board per se, but it was a presentation of the dashboard, which is where they had done this analysis of drugs and compared the cost, how many people with the specific disease treated by that drug resided in Colorado, what was the public cost for these drugs. And from that very first meeting, they were asking for public input. What did people think about this dashboard? And really at that very first meeting, I said, I just want to be sure, like, our quality adjusted life year measures being utilized here? No. That's banned by the legislation. We cannot use quality adjusted life year measures. And, clarification, can there be a consideration of rare disease drugs? Not at this point, So moving through the process, and there have been multiple hearings, I would say one of the highlights for me, I am the executive director of the Cystic Fibrosis Research Institute. For those not familiar with CF and just the shift in our realm, over the past, in fall of 2019, a drug called Trikafta was approved. It's a triple combination drug, a CFTR modulator that essentially, for some people, it cannot reverse the impacts of the disease, but it can absolutely improve health. And for some people, it has not been, a miracle drug, but it is stabilizing. For other people, there are the stories of people who literally were on their way to get a transplant. They were on oxygen 24 hours a day, on disability, who are now off oxygen, off the transplant list, working full time, off disability. So it's for some people has been a remarkable drug. And not to go too into the weeds with this, but a point I want to make clear, because it reflects issues with the PDAB in Colorado, is that that drug can be used by about 90% of people with CF. And so people always talk about 10% of people with CF cannot benefit from this drug. But when you really look at that 10%, that 10% is comprised largely of people of color. And it's because CF has many disease mutations, and this therapy is mutation specific. So I just want to bring that up because this plays out later when you look at these drugs. Who is being impacted? Who are they helping? Who is still, would not lack of access to this drug really increase disparities in healthcare? So I will say the CF community, excuse me, has mobilized wonderfully in Colorado. And there have been multiple meetings of the board. There have been meetings of the advisory committee. They have had listening sessions for stakeholders. And as Sara pointed out, they divided them so that there was a listening session for patients and care providers to come and share their input. There was another one for clinicians and Vertex, the company that makes the drug, to come present. And they held those for each one of those 5 drugs. I will say, obviously, there are issues. One of the drugs they're reviewing is a drug for HIV. That might be a community that has privacy concerns for showing up and testifying, possibly. CF community, they had one of the listening sessions. 85 of us showed up to testify. It went on for a very long time. They had to reschedule, add a second hearing for this. But coming really back to the point of transparency in the process. Through this, at each stage, key questions have been for us, rare disease carve out A. B, the other question was about the use of QALYs. And we have been told repeatedly, it is banned, it is banned, it is banned. However, if you really drill down, the truth of the matter is it is banned in the selection of the drugs. So as they were considering which of those many, many, many drugs to evaluate, they were not able to use any kind of quality assessment. However, when I had a follow-up, there was, we had a sign-on letter saying we need full transparency. We want guarantees that there will be no use of these measures, discriminatory measures. And I got a very angry call from the staff member who had heard about this letter. She says, this is wrong. This is just so wrong. I've told you, we have said we cannot use this in the drug selection. And I said, well, you've already selected the drugs. We're on to the next major phase, which is economic review. What's going on there? Are you going to use an ICER report as you review? Because I can tell you the ICER reports on those CFTR modulators were an affront to our community. They were horrific. Were so non-patient centric, absolutely no proper measure of value, and determined to be really not worth the price. So I hope you're not using those. Oh, well, actually we are. We're using studies from every avenue. So if you have any reports you want to send me that you think would be better, go ahead, which I did. But the point was, please don't keep telling us that this is banned. We're not using this. Really, one of the most important sections of the review is the economic impact. And instead, that is where very non-transparently, once you drill down, QALYs are being used. So I think it was a great heads up, I think, for all of us. Like, there is no point along this process with the PDAB that you don't engage, meet with staff. I mean, I will say that is one thing that the staff in Colorado have been criticized because they've been like a firewall from the board. On the flip side, they also have made themselves available. So there's no downside to fully engaging, even if you think they're acting as well. Actually, even more so, better to engage with them. So it's been a very interesting process. The board will meet on December 8th, and it is predicted at that point they will clarify whether or not they will be putting the price cap on Trikafta. And Oregon just amazes me with the sheer number of drugs that have been identified, because 5 is a lot when you think about all the time that goes into each of those. And in fact, in Colorado, I mean, they're postponing, they couldn't get through the 5. I think they're looking at 3 drugs, so 2 or 3, that it is so unreasonable. And of course raises red flags about what will be missed from the patient perspective if they are rushing through this process. So I'll just stop there. I hope I didn't
Thank
ramble
you.
too much.
So Jen Laws, I see you're on the phone, and I know that I've heard you speak about this before, and I don't know if you have any additional thoughts for the Oregon advocates.
Hey there. I appreciate you reaching out, Sarah. It's good to see you again, Siri. We've been on a bunch of the Colorado calls, and to be clear, Community Access National Network is working across several states. Our partner, Health HIV, has already been in the Oregon process as much as they can. So we're trying to take lessons learned. One of the big things that we're trying to encourage folks to do in addressing qualities as an issue is to name the entities you know that are using them. So don't leave it just blanket. Like I saw a letter that's being drafted today for Colorado that says don't use qualities, and that's all it says. And a lot of entities won't outright say, hey, we're using qualities, but they will. And in Maryland, we're seeing discussion of European pricing models. Each and every one of those use qualities. So that's one of those dig-in spaces where you really do need to be specific as you engage. The other thing is encourage one of the things we really struggled with in the HIV space. We've got a national program that's federally funded in each and every single state. It's the Ryan White HIV/AIDS program. And each state, each public health department for each state has to engage patients and providers and community members in this space. But the Department of Insurance in Colorado didn't bother to reach out to the public health department. And indeed, one of the administrators for the public health department before they quit said, don't engage. Which creates a really big problem when it comes to patient engagement, right? Like you're not actually reaching out to patients. One of the data reports that we're seeing coming from staff doesn't include a denominator for how many people took their surveys, and their surveys are biased in design. They don't talk sufficiently enough about where public health programs are engaging in terms of reducing out-of-pocket costs, increasing access. They don't talk about other system issues like consolidation in the pharmacy space, or any of these other problems that really talk about patient affordability. And one of the things that Ken has kind of leaned into is that this idea of a prescription drug affordability board isn't really about patients. It's about payers. It's about reducing state costs, but all of those things are kind of short-sighted. When Ohio had a advisory board to evaluate different mechanisms of action which might reduce system costs, a UPL wasn't one of them. Not a single one of them. Subscription purchasing, consolidating state purchasing models, things like that were what was brought up, including patient protections are what was brought up, because we know that it costs far more for the system and the individual to be in the hospital for 2 to 3 weeks to be stabilized because we've had a disruption in care that's made us sick. So bringing up these issues has been really kind of critical in talking about like what it means to be affordable or to save the state or individuals dollars. The other thing to point out is that at least with Colorado model is there's no requirement of pass-through of savings. And that's really a big thing for the legislators that are interested in being involved. Kind of looking back at this, they were sold on this makes things cheaper for patients, but that there's no evidence to that effect. And pointing out that there's no evidence and that there's no requirement in the model legislation that was used to put this issue up is quite valuable. Also have an answer for that. We've been leaning into addressing and prohibiting spread pricing as our preference, including things like utilization management protections for patients to increase actual access. So having those things at the ready, thinking about what it is you need is very, very important. Knowing what it is you want to get out of it. If you want to, like for our Community Access National Network, we argue patient access every step of the way. And it doesn't matter whether we're talking to our industry friends or legislators or regulators or anybody else, right? So whose voice are you representing? What are the particular issues that are important to you? What role does each stakeholder in the drug channel play in terms of access? And what are the other systemic issues? What are the confounders? If I say that I can't access my drug, is it because the CVS just closed down 400 stores in my state, or Rite Aid went out of business, or there's a software problem at Walmart pharmacy? Just dealt with that for a state payer, right? So what is the issue and concern? Are patients being adequately educated about patient assistance programs? Things like that. Like what are you asking for? What's your aim? What's your goal? What's most important to your patient base? As a person living with HIV, the Genvoya selection is kind of scary. And what I'll say is there are two angles to that. One is reduction of rebate dollars that are used to fund public health programs, particularly hospital systems, is a big concern for us. If the state's not going to invest it, who is? And then the other thing is this adverse selection process that will prioritize things like utilization management, PAs, step therapy, things like that. And it's particularly important with Genvoya because Genvoya is not a standard of care medication any longer. So now if the state finds preference, then it's finding a preference at the expense of patients getting standard of care medications. So this is like, there's layers and layers and layers to this. Think about the angle that you're most comfortable talking about. Think about the issue that is most important to you. And dig into that. The other thing is find allies, because this stuff is exhausting. It's happening everywhere. The meetings are like, sometimes we're seeing 2-3 of them in a month. When they were doing the patient engagement sessions, we had to ask for multiple meetings, and Lila and staff have been fabulous about that access and communicating transparently. That said, you're going to need friends in getting through this and being able to balance your own needs, your own health issues as patients that are advocating. So that's, sorry, little monologue.
No, that's very, very helpful. One thing we've also been working on at PIPSI has been the CMS listening sessions related to negotiation, there was a lot of critique about how it was done. And it feels like the states are in a similar pickle where, like, there may be a listening session, but it's not communication. Right. I mean, there's no back and forth, asking questions, ability to kind of get under the hood of what is it that they're looking at in terms of the evidence, and like, what are the considerations that are going into these decisions, right, that allow for a response from patients. So I don't know. There seem to be a lot of analogous things going on there. So this is all really interesting. I don't know. I mean, in Oregon, and Paul, I'm not to call you out, but I'm curious, like, where things are with the HERC, because we had such a, I thought, robust, positive engagement with them to get them to do things differently. Like, and it doesn't feel like that's translating. Am I wrong?
So we made a lot of progress over the last couple of years. The NCD project that we worked on, even though that report hasn't been published, it certainly got attention. The work on it got attention within HERC. So they have made sort of commitments to us that they're saying the right things. They made commitments about not wanting to use qualities. I think the question is really in the details. We had we tried a legislative solution last spring that didn't really work out for a variety of reasons. And just the nature of that is that once that got filed, their ability to engage, procedurally, their ability to engage with us sort of went down until that was closed. So I think we need to follow up with them more and see what we can do. I gather from that there may be another attempt to do another bill in February. The short February session that we have coming up in a few months. So I think, I mean, the key thing is I'm not hearing anybody from HERC saying, yes, we love qualities, we want to use qualities. It's more like a, hey, we hear you, how do we fix this? So I'll call that progress.
No, yeah, I hear you. Okay. But I guess then where I've gotten confused in terms of trying to look at Oregon is you have the PDAB, the HERC, and then you have this other drug price transparency thing. And that is distinct from this PDAB process, but yet the reports coming out of that process look very similar to what I see coming out of the PDAB process. And you've got PDAB putting their meetings front and center on their website, but these are not related things, are they? I mean,
So it would be nice to imagine that a state like Oregon would be like really closely coordinated and organized and strategic in how all of these groups are put together. But I mean, basically, you have a legislator coming in doing one thing, you've got another legislator coming in doing another thing. The agencies are compelled to do what they're told. And so, I mean, you're not going to have an agency speak and say, hey, by the way, maybe we should tweak this legislation and align it better, because they're basically compelled not to do that. I have in many cases over the years had agencies whisper in my ear, by the way, this law is kind of messed up and maybe we could fix something, but they can't say that publicly. They're forbidden. And I happen to have a call with the insurance commissioner in a couple of days, and Lauren, I'll invite you to that. And so I can just sort of have some informal discussion with them about some of these kinds of things. Like, as an example, why aren't there consumers on this board? Well, because the legislature didn't write it in.
right.
We can fix that. Go back to the legislature and ask them to tweak it. But I think basically just bear in mind, we've got 90 legislators coming in and doing different things, and they're not necessarily coordinated. And frankly, the legislators, even on the healthcare committees, don't necessarily understand the health code and the health system. So,
Yeah. Okay. No, that's helpful. There was such tremendous progress, I felt like, with the HERT, that it is interesting to me that the engagement practices that were so important don't seem to have translated. And I guess I know that from the listening, like in the listening sessions at CMS, there was concern that consumer groups were showing up at the listening sessions that weren't patients, right? They were more from like the
Right.
public citizen types that were, but not people with like a genuine experience with the disease or on treatment weighing in, right? And I don't know, like, if that's still a problem.
One of my sort of key things for many years has been that we really need to do a better job of getting patient input in. So Lauren recently has pulled together a group to try and work on that. A decade ago, the insurance division set up on their own initiative, but then the insurance commissioner moved on to other things, and that sort of dropped. And part of why I'm inviting Lauren to this meeting with the insurance commissioner is that, hey, we've self-organized, and let's go bring it in. Because we really need more of that. I think they want that kind of input, but they don't. I think the government doesn't really know how to sort of get it in effectively, and so I think if we can sort of self-organize and sort of bring it in, that'll make it easier.
Yeah.
I mean, the other issue I have with this process is, great, so they've made a decision, a recommendation that a drug price is too high. That's nice. What are they going to do about it? Does Oregon have the power to go to, Amgen and say, hey, cut your price? No.
Mm-hmm.
So that's actually a question I have for the Colorado group, and anybody with experience in Maryland. Have any decisions been made, and what have they done about them? I mean, because that really is our question. Like, what's going to happen once they make this decision? Has anybody made any changes? Do you know?
They haven't. I mean, the meeting next week will be the one where they make probably their first announcement. But that was literally in the beginning. I don't know how this was for you, Jen, but I was like, what is this going to mean? Okay, in the end, they're going to decide the price is too high. And which I will just, as a little side note, the one thing that became very clear at one of our listening sessions was, please stop talking about caring about the patients. We actually have access to this drug, because part of your formula better be looking at assistance programs. There are no generics for this. This is the drug. please stop saying it's about us. It's about the state. It's about payers, because we all have access to the drug. We're only fearful now because of this process. So then the question was, well, what will happen if they put a price cap on? And Vertex says, are you kidding me? We are not going to meet, we will not sell our drug for that price. And what a precedent it says everywhere, it's US, we can critique our medical system, but and they basically, I mean, the veiled threat was, yeah, you put a price cap on it, people are going to have to be getting their Trikafta in other states, because we're not going to be told that, you know, that's contrary to the laws of our political economic system. So I don't know what you've heard, Jen, for Geneva.
Yeah, I mean, realistically, that's all they can do. They can say, well, we're just not going to pay it, so those patients are out of luck. I mean, that's really the only lever Oregon has.
Well, and it depends on the scope of the legislation. So in Colorado, it would, the legislation forbids any pharmacy or payer from reimbursing above the limit that's set. But nothing stops a pharmacy from charging a cash price higher than that. Nothing stops, see, and it's actually the last paragraph in the preamble, I think, for the legislation in Colorado. Siri, I'll send it to you. It emphasizes the payer process, pharmacy process, the state dollars, right? There's this focus that is kind of like a bait and switch in how it's sold. Now that said, they've not made any decisions other than what are the drugs we're going to look at for affordability. What are the other decisions they've made are kind of process decisions. You know, how are we going to engage with patients? Like, what's that look like? And they're going to open up their policy document in February, because we've all been complaining quite a bit about how it's not meaningful engagement with patients. If you're holding a meeting and saying, well, we'll see who shows up without actually sending invites, that's not meaningful. So that said, you've got to ask the question, who pays the difference when the acquisition cost is higher than the reimbursement rate? And one of the things that we've noticed in HIV, and we see it in some oncology stuff, we certainly saw it in the 90s, is it opens up a black market risk where folks might be sending in counterfeit medications from Canadian pharmacies, or reselling diverted medications. There's a massive risk, because that's what happens when we decide that we're not going to have the dollars for that. It's not just a matter of will this manufacturer pull out. It's what happens to patients in the meantime. How much is that going to increase the state cost? What kind of illicit market are you encouraging? Because folks who are desperate for getting care will do anything it takes to get it. That is life and death. That is watching my child get sick. That's watching my lover get sick. It is life and death. And that includes driving across state lines or any other activity in order to engage in illegal activities. That's what this does. And I will point out that in Europe, manufacturers are threatening to pull out. It's been a big piece of news recently. Indeed, regulators in Europe decided to just double the allowance for drug growth as a result of these intense kind of restrictions that they've got on reimbursement, and what patients are allowed to take. And at the end of the day, that's rationing. And my life is not going to be rationed. I will kick and scream, and there's going to be a hell of a fight. We used to throw blood and condoms on people. Like, I don't want to go back there, but if you want to, we will. So
we track a lot of what happens in Europe as part of PIPC's advocacy against international reference pricing, because of the sort of disability discrimination that happens in Europe, and a lot of the decisions that get made there not where people cannot get access to care. And so if you go to the PIPC website, there's under issues, if you click international, we have like kind of a scroll of international stories that we maintain there, to make exactly that point, that it's a significant challenge. And even in countries, it's interesting though, because even if you look at countries where they don't use QALYs, and this gets into the weeds, right? Which is really hard, because you start to get into the weeds of what product are you choosing as your therapeutic alternative? And that's the product that you're going to compare these other products to. But how do you select that product? Is it truly comparable? And how are you measuring whether or not one product is better than the other, right? And that's when the issues I was talking about before, when it comes to like health utilities and quality of life measurements come in, because if you're not measuring those things well, you could be inadvertently devaluing the value of a product that's like Trikafta, right? Is clearly a mind-blowing improvement over the previous generation. So, but are you capturing that in the evidence is really the key issue, and how that evidence is generated is a big deal, but not necessarily something that everyday patients are going to be able to speak to, right? But it is a really important part of the process that, frankly, they don't necessarily get right in other countries. Going forward, I guess I would just leave you with, there's a need before this next meeting potentially for the patients in Oregon to get together around some recommendations that could be submitted by the December 10th deadline. And I think this is probably just the start of a conversation, but
Later that I was meeting with, he said, basically, every day we are drinking from the fire hose. So,
Yeah.
I mean, that is the reminder of like so much legislation, and it is imperative that patient groups organize and be consistent. And just as Jen said, just consistently, you need to make this the issue they care about. They can't ignore it anymore. It is the standout from that fire hose.
Great. Wow. Well, thank you all so much. Great information, really, really helpful. I am definitely going to get this up on our website so other people in Oregon can watch it. Really appreciate it, Sarah and Siri and Jen, really very helpful.